Welcome to the Neurosurgical Case Room. Am I audible?
Walaikum assalam. Yes, you are, ma'am.
Thank you. So let's proceed without further ado. We have already gotten 5 minutes late. We are going to cover anatomy of insula, and it should not be really difficult after we have done Sylvian fissure and frontal lobe anatomy, temporal lobe anatomy. They are what cover the insula. So if we are clear about them, then it's a lot easier to approach the insula. So let's start. So it's also the fifth lobe of the brain. It is also called island of the rail, usually pyramid shaped. It's a cortical structure. And it is different because it lies under two other cortices. So it's hidden. You cannot see it from the lateral surface. Limits are defined by the circular sulcus. We all know that. I'm going to show you the images, so whatever I'm saying makes more sense. The limit is circular sulcus, which is also known as peri-insular sulcus. It is deep in the Sylvian cistern. It has 3 segments. It goes like this. And let me see. Let's draw a very rough illustration of insula, the frontal operculum and the temporal operculum. So this is insula, this is frontal operculum, this is temporal operculum, and what you see here is the Sylvian fissure. The portion which is adjoining right over the insula, this circular thing, this is called the circular sulcus, also known as the peri-insular sulcus, right? Then it has 3 portions. Easiest one is the superior one. Let me change the color so that you can see it. It separates the insula from the parietal, and if we go slightly posterior, then from the frontal, it separates from the frontal and then from the parietal as well. Please mute yourself. It disrupts my chain of thought. So this is the superior portion, and let me change the color. This here is the inferior portion. So understandably, the superior portion is separating the insula from the frontal and the parietal opercula. The inferior portion is separating it from the temporal opercula. We have covered this thoroughly in the Sylvian fissure. Then anteriorly, there is a small portion of circular sulcus which separates from the orbitofrontal operculum. We are going to look at it in the images ahead. I clear all of it. The problem with the anatomy is you cannot cover it as individual sections. If anyone who has joined us today has not gone through the Sylvian fissure and the temporal lobe, it would be slightly difficult because there will be no background. Let me draw again. So what ends up happening is insula is divided in 2 distinct zones. There is a central sulcus of insula as well. And interestingly, it follows the central sulcus of the main lateral convexity. The Rolandic fissure, the central sulcus, it marks on the lateral surface. Underneath, on the insula, we have the central sulcus of insula, which is following the same orientation, and it divides insula in 2 portions, the anterior portion or the anterior cluster and the posterior portion. So anteriorly, there are 3 to 4 small gyri, and they radiate from the apex. So basically, insula is shaped like this. There's this triangular sort of apex here, and there's a circular sulcus, and then we have the central sulcus, which runs here. So the gyri, they sort of branch out like this around the apex. This is just an illustration. Please ignore my poor drawing. So we have anterior short gyres, we have middle short gyres, we have posterior short gyres, and then we have accessory gyres, which is sometimes present, sometimes not present. Dr. Lalitha, please mute yourself. So let's move to the next slide. Posterior cluster is what is behind the central sulcus. It has 2 long gyri, which are oriented more vertically. There is an anterior long gyrus and there is a posterior long gyrus. It will be a lot easier once we begin looking at the images. So if you see, it does look like an inverted pyramid, sort of. You see, it's an inverted pyramid. And this is the apex. And if you look at the orientation of the gyri, they are fanning out like this. Let me change the color so that I can show you the central sulcus. Now, this is the central sulcus. And if we look at it in a coronal section, then we will see that the central sulcus of insula overlaps with the central sulcus on the lateral surface. Anterior to this, we have the short gyri. You can see these purple colored structures, which are the sulci, and the structures that are in between them, which are the gyri. And then posterior to the central sulcus, we have these long gyri, long anterior and long posterior. Are we all clear so far? Can someone unmute themselves and let me know?
Yes, ma'am, clear.
Thank you. So this portion here, this is the apex of the insula. When we talk about apex of insula, there is another structure that comes to our mind, which we will see when we look at the deeper dissections. That is limen insula. So clear and move to the next slide. So this is, let's begin from the easiest section. This is an unretracted image. You see the frontal opercula at their original position. You see the temporal opercula. You also see the parietal operculum. They are all there. You see that the Sylvian fissure has slightly parted. The posterior ramus has slightly parted. This is the frontal operculum. This is the temporal operculum. But from the parting, you can sort of visualize a very small portion of insula that is visible in between. These are the short gyri. These are the long gyri. So now you will have to imagine from here that we are going to retract this, that we are dissecting this, and we are retracting these lobes far apart to open the structure underneath. Let's move to the next image. Now you can see that this has been completely retracted to expose the underneath cortex, which is insula. And circular sulcus runs over here like this. You cannot exactly visualize it in this section. We have coronal sections ahead, so you will get a better idea of this. But just so you know, this portion which separates it from the opercula is the circular sulcus. Then you can see the long gyri here. And you can see the short gyri here. This here is the lateral sulcus. The long gyri are posteriorly, the short gyri are anteriorly, and this portion here, which was right at the anterior Sylvian point, is the limen insula, which overlies the uncinate fasciculus. But we are going to come to it later on. Also, not a lot of books write it, but it's important to know that since this point here is the anterior Sylvian point, there's also a posterior Sylvian point, which is somewhere around here where the Sylvian fissure ends. There's a posterior Sylvian point. It is sometimes referred as just the Sylvian point, sometimes as posterior Sylvian point, depending on the author of that anatomical textbook. But you should remember so that you do not end up confusing Sylvian point and anterior Sylvian point. Move. Now we have taken away all the cortex, and what you see is a beautiful, beautiful dissection of white matter tracts. Let me draw here. This image is so beautiful that I don't even want to draw over it. You can see all the white matter tracts here, corona radiata and etc. We are going to come to them later on. You can also see the superior longitudinal fasciculus, which has been cut here. And just so that you can imagine, this portion here will also have arcuate fasciculus. Why is it important? We will come to it. So somewhere around here, we are also going to have the arcuate fasciculus because it is going to connect the vernix area and the Broca's area. And why is that important? Because this vernix area is going to be in the vicinity of posterior insula. So just for our future discussion, remember this, that somewhere around here, obviously the cortex has been taken away. Somewhere around here, there's a portion of vernix, also a portion of primary auditory cortex, and the posterior insula is in contact with it. Okay, let's move. So here the cortex has been retracted. Along with the retraction, some portion of the cortex has been dissected away as well, so that you can see it more clearly. The markings here are for the deeper structures, so ignore them, the levels, etc. But look at this. This is an image from the roton, and it was not marked, but I marked before I included it in my presentation. You can see that this is the central sulcus over the lateral surface. And you can also see that this is the central sulcus of the insula. And how interesting is this, that this direction and this direction is coinciding. So this is the point I was making earlier, that both of these overlie each other. Let's move. So you can see the same image without the marking, and you can see if you follow my cursor that this is the central sulcus. From here, the cortex has been removed. You see the insula underneath, and underneath, this is the insular central sulcus, which is in the same direction as the central sulcus of the lateral surface. Dr. Hadije. Yes, we discussed it in a previous session, doctor, that there is a difference of opinion between the arcuate fasciculus and the superior longitudinal fasciculus. There are some authors that say that superior longitudinal fasciculus is a completely different structure, arcuate fasciculus is a different structure. There are some authors that say that arcuate fasciculus is just an extension of the superior longitudinal fasciculus. We have discussed this in the Thursday session, I believe, very, very thoroughly.
Okay, thank you very much.
Yeah, I would recommend that you can start watching from the Sylvian anatomy and then the temporal lobe and then the frontal lobe, so that it all ends up connecting the dots, because there are a lot of finer points that we have discussed in previous sessions that then I don't end up repeating.
You're right, I will do that. Thank you very
Yeah,
much.
I think you are a new joinee. Where are you from?
I'm from Germany.
Okay, amazing. I'll make sure that I leave the links again. So
Thanks.
this image is here, even though we have discussed this image during the Sylvian fissure session. This image is here again because it shows this is the circular sulcus. It shows the circular sulcus. It also shows the Sylvian cistern and the opercular insular segments, etc., that we have done very thoroughly. But what portion of brain is this? What is the orientation? Can someone unmute and let me know?
AP view, madam. AP view.
No. What surface are we looking at?
Inferior surface.
This is the inferior surface. That's right, Dr. Lalita. Thank you. This is the inferior surface. You can see the anterior perforated substance right here. You can also see the chiasma going around here, optic nerves, etc. And this here is the anterior perforated substance. If we follow it, here we have the uncus, right? Or no, I'm not sure about the uncus. It's taken away. Let's not go there. But once we follow this is the Sylvian cistern. And this is again a portion of the Sylvian cistern. This is the operculo-insular portion. The only sulcus we are concerned about is this. It is the sulcus that separates the insula from the frontal operculum and the temporal operculum. And interestingly, you can see limen insula here. which is not as visible clearly, but this is here. And if we strip this gray matter away, if we strip it away, we are going to find a band of white matter tract underneath, which is going to be the uncinate fasciculus. Move this. So, limen insula has been discussed very thoroughly in a lot of previous sessions, but it's so important that I didn't want to skip it again. It is the anterior-inferior threshold. We are all clear about it. Let's go back. This is somewhere where the limen insula is going to be. Move this. It overlies part of the uncinate fasciculus. And why do we use it? We use it to identify the bifurcation or the trifurcation of the MCA. It is the transition from M1 to M2, and it is the point where the sphenoidal segment turns into the insular segments. We are going to see all the images ahead. Genu of the MCA, you can find it here. Lenticulostriate arteries are they are probably of the most significant surgically because they arise from M1 proximal to limen insulae. Let's go back to this image to make more sense of what this said. Imagine that there is MCA running here. We all know that this is part of the Sylvian cistern, right? And MCA is running here. This is limen insula. And you can also see that this here is the anterior perforated substance. So if MCA is running here, M2 is going to start after the limen insula. Till here there is M1. And there are lots of smaller branches, which are called these lenticulostriate arteries, which perforate the brain, the inferior surface of the brain via the anterior perforated substance. So what limen does is it helps us identify this portion. Because if we end up sacrificing these small perforators, patient can have an infarct in caudate, in internal capsule, etc., and it is going to result in significant neurological deficit. Clear this and move. So once you identify the limen, it's your borderline. You know that you cannot go beyond the limen, because if you go beyond the limen, you end up risking the perforating arteries and the blood supply of the internal capsule. So you can see that the cortex has been stripped again, and you can see corona radiata here. And the corona radiata is converging and condensing in this. This is the internal capsule. Corona radiata are simply, they are huge fibers. They fan out. Hence, they're called corona, because they are like radiations and then they fan out. So these are like sun rays. And then they condense very densely. An internal capsule is nothing but a condensation of these corona radiata fibers. And we did discuss that internal capsule, once it leaves that portion, it ends up becoming crus cerebri. So these are the vertical fibers, corona radiata, from corona radiata, internal capsule, from internal capsule, we have the crus cerebri. So we know that insula covers the deeper cortical structures, which would include the caudate, the putamen, the lentiform nucleus, etc., along with that internal capsule as well. So it's easier to identify once you imagine that there are these fibers going down here. Now, once we strip all of this away, once we strip this cortex, we are going to find internal capsule down there. I believe we do not need to go over the insular sulcal and gyral anatomy again. I think I did make a point. You can see the superior longitudinal fasciculus here. There are optic radiations here, which is the retrolenticular part, I believe. Clear this. Let's move on. If you understood this image is going to be a lot easier. They have stripped the insula completely. The cortex has been completely taken away. And what you see is the internal capsule And then you see the putamen. You also see the uncinate fasciculus, which was covered by limen insula somewhere around here. So we have completely uncovered all the white matter tracts which are lying underneath. We have the uncinate fasciculus, we have the external capsule, we have the optic radiations. Just give me a minute. And you can also see the superior longitudinal fasciculus. So let's look at the inferior surface again so that it's a lot easier. This is the frontal lobe and the inferior surface, and we are also looking at part of the insula. The temporal lobe has been stripped away. It's really important to orient yourself with the face and the lobes of the brain that you're looking at in a dissection image, because otherwise you'll be very, very disoriented. You can see the anterior perforating substance here, right by the optic tract. You can also see the limen insula, which is marking the end of the anterior perforated substance, and M2 is going to go like this. The short gyri are visible, the long gyri are also visible. Clear this. These illustrations might not make sense, but I promise the next ones that are coming will make sense. So you can follow the MCA here, and this blue portion is M1, the green portion is M2, the yellow portion is M3, and the red portion is M4. If you see, this is following the sphenoidal compartment of the Sylvian fissure. From there, you see that it is bifurcating. MCA is bifurcating, and there's a superior trunk, there's an inferior trunk, and then you see parts of it going near the insula. These portions are, what portions would these be? These will be M2. The green portion is M2. And then the yellow portion is M3. And then the red portion, which are the terminal branches, these are the M4 segment. In the first illustration, the Sylvian fissure has not been retracted. In the second illustration, the cortices have been completely taken away. All you see is the insular cortex. So I think this would make some sense. It's a clearer image. You can see that M1 is following here. This was the sphenoidal portion of the Sylvian fissure. And then we have the M2 and M2, which is going in the circular sulcus. And then we have this M3, which is in the opercular portion of the Sylvian fissure. And then the cortical branches, which come out like this. Is it clear now? Can someone unmute themselves and let me know?
Yes, ma'am.
Yeah.
Thank you. Let me see this. Okay. The second image is just a coronal section that has been taken slightly posteriorly. The first illustration is A, so it has been taken at this level. B is an illustration that is taken at a slightly more posterior level. So you are not going to see the M1 segment here. All you are going to see is the M2, the M3, and the M4. And here is the circular sulcus, which is traversed by this M2. The superior portion is the superior portion traverses in the superior portion of circular sulcus. The inferior portion travels in the inferior portion of the insular sulcus, central circular sulcus. The names are so similar that I keep messing them up. So let's zoom out slightly. This is a very zoomed in image. And it's here so that we get some idea what happens if we cut through the insula. This is an axial section, by the way. We see. Yes, this is an axial section. And you can see the insula here, which is marked. And then we see the claustrum. Change the color so that it's visible. We have the extreme capsule marked in the orange. And then we have the external capsule marked in the yellow. And then we have the putamen and the globus pallidus, etc. The lentiform nucleus that we called. Now we all know that insula is a gray matter, right? Then extreme capsule is white matter. External capsule is also white matter. Between these two, there is a very thin layer of gray matter, which is called as the claustrum. So after insula, claustrum is the only gray matter you're going to find. Then you will find the external capsule, and afterwards, the gray matter that you find is the subcortical nuclei or the basal ganglia. This is also an axial section, and this one was very zoomed in. If you slightly come out, then this is how you're going to find how beautifully visible is the circular sulcus here. And right underneath the circular sulcus, this entire portion is the insula. And in this section, you cannot appreciate the claustrum, the external capsule, etc., etc., but you can look at the lentiform nucleus here. And you can also look at the internal capsule, the anterior limb, and the posterior limb, the genu. And then there's head of the caudate. Now, this is the image that we usually see in the axial sections of the CT brain. You can also see the thalamus, just right underneath the posterior limb of the internal capsule. Are you all with me?
Yes, ma'am.
Okay. Let's go back. And now in this image, you can see two different orientations. The image itself has been cut in the sagittal view. So all these structures that you see here are sagittal. But then interestingly, they have cut the insular section as axial. So you see the sagittal view, and then you also see the axial view, so that it's easier to identify the deeper structures through the insula. The orientation might be confusing, otherwise it's a very straightforward image. What you see here, if this was not cut, then you would have seen these sulci extending like this. This would have been covered by insula. What they have done is they have gone on and sliced the insula in half so that the underneath section is visible. You can see that the gray matter is ending here. And then we have the lentiform nucleus. This is the internal capsule, the anterior limb. This is the posterior limb of the internal capsule. This here is the thalamus. And this here is the caudate nucleus. And how beautiful is the image of foramen of Monro here. And you can see the lateral ventricle above. My screen would not allow it. And you can also see the choroid plexus, which is traversing this entire portion and it's going back to the temporal horn. So this section that you're seeing, this is in sagittal section. Not mid-sagittal, but it is still sagittal. You can see the choroidal fissure here and the choroidal plexus. This is an axial section. The ventricular anatomy is visible and the basal ganglia are beautifully visible. The insula is visible. They are all same structures. These are just different views so that you get a very good orientation. This is the circular sulcus, the insula. Then we have the lentiform nucleus. And then we have the internal capsule, the anterior limb, and then the posterior limb, and then a very small portion of the thalamus here. And inside, you can see the lateral ventricles, atrium, etc. You can also see the choroid plexus. Thalamus is visible here. On this side, it has not been dissected. On the other side, it has been cut. This is the same image. I think by this point, all of you would be very sure. These are again axial images. How do I know? I know because of the shape of the frontal horn and the lateral ventricles. They are very typical, just what we are used to looking at the CT scans. You can see the foramen of Monro, which is going down. We have the choroid plexus here and circular sulcus, which is closed completely. Let me change the colors because the image is not as clear. You can see extreme capsule here. It's not as visible, that is why I'm marking it. Then we have the external capsule somewhere around here. In between them, we have this claustrum, which is nothing but a band of gray matter. And underneath this purple thing, which is the external capsule, we have the lentiform nuclei. Clear? Let's move. So from surgical point of view, what we at least need to know if we cannot retain all of the insular anatomy. The Berger-Sanai classification system is something that we all should know. Whether we are residents, whether we are early career consultants, it's not something you can live without. If you are planning to go Sylvian, insular route, or if you're planning to do insular lesions. So Berger-Sanai classification divides the insula in 4 zones. I'll make a very rough illustration so that you have some idea before we see the actual images. We have these 4 zones. These are rough. They do not follow the Gyral and Sulci, which we discussed previously. They were the anatomical demarcations, etc., etc. This is more of a functional classification. So Berger-Sanai divide the insula in 4 zones. This is zone 1. And then this is zone 2. This is zone 3. This is zone 4. Now, if you all remember the insular anatomy, this portion here was in contact with the frontal operculum, right? And the lower portion was in contact with the temporal operculum. Let me mark here. You'll have to imagine that there is temporal lobe here. And let's change the color. You'll have to imagine that there is frontal lobe, which is also extending up to the parietal lobe posteriorly. And somewhere in between, we have this central sulcus here as well. So what ends up happening is zone 1 is anterior superior. Its location is superior to the Sylvian fissure, anterior to the apex, and the surgical risk is that it is adjacent to the frontal operculum. The reason I drew this rough illustration. In the dominant hemisphere, this might mean that Broca's area is either involved or there will be a very strong connection between insula and the Broca's area. So zone 1 might result in temporary loss of speech, temporary aphasia. Also, it is important to remember that insular deficits are, most of the cases, they are transient. They are not permanent. They end up resolving in a month or 2. There are probably 20 to 30% cases where the deficit will be permanent. So that's a good thing. But nevertheless, zone 1 can hinder the speech. Zone 4 is concerned with the personality, it's concerned with olfaction. So it is more or less has a vague function, can be compromised. Zone 1 is more of a problematic thing. Zone 4 is adjustable. When we talk about zone 2 is in close vicinity with the central sulcus. So we have to keep that in mind. Right, I think I forgot to make another. Zone 2 is around the central sulcus, the motor strip, and zone 3 is around the vernix area. So 1 is around the Broca's, 2 is around the motor and the sensory cortex, 3 is around the vernix, 4 is around the olfaction, etc. The deficits are going to depend on them. Clear this? So that we can come back to the text. Zone 1 is anterior superior. And the surgical risk is Broca's area because it is adjacent to the frontal operculum. And I think we discussed that. Let's move to the next slide. Zone 2 is posterior superior. The surgical risk is highest here because deep to this, we have the internal capsule, and we also have the motor and the sensory, the primary cortex is right over it. So this is a very high risk zone. Zone 3 is related to the temporal operculum and the vernix area. Medially, it sits near the optic radiations. And zone 4 is this is probably the least risk zone. The only problem here is if you breach the limen insula. If you end up breaching the limen insula, then patient will have an infarct of the internal capsule. Why? We have discussed that before, because this demarcates the origin of the lenticular-striate arteries. So as long as you stay before the limen insula, it's not going to risk the patient. The other problem is that M1 is going to run around here. So if you secure the arteries, which we have discussed before, we use this subpial resection technique. We respect the pia so that between the vessels and us, there is pia, and then there is this arachnoidal covering of the vessel. Subpial resection and taking care of the lenticular-striate arteries, we are good to go. Zone 4 in itself is not as eloquent in comparison with other zones. Now, let's look at the actual illustration. This is the foramen of Monro axis, and this is the Sylvian fissure axis. These are the imaginary axes that are used to demarcate the insula into zones. Zone 1 is here. You can look at this. This is zone 2. You can see that central sulcus is running around here. This will be in contact with the primary motor cortex, the primary sensory cortex. Deep to it is going to be the internal capsule. Here we have the vernix area, and inferiorly, this is negotiable. This is a simplified illustration and nothing new on this image. So we are not going to spend more time on it. Zone 1 and 4, if you look at it again, they are easily accessible because they are in the initial portions of the posterior ramus of the Sylvian fissure. So the extent of resection is a lot higher in the zone 1 and 4, whereas if you compare it from the posterior zones, the extent of resection is comparatively lesser because the axis is less. There is only a certain amount that you can retract. Zone 1 and 4 have higher rates of GTR. Zone 2 is the most frequent site of subpleural resection because there is internal capsule just underneath it. So that's it for today. That's a wrap. It was a long session, but insular anatomy is not something you can cover in 30 minutes or so. Any feedback, any questions, they're all welcome. If you can't think of any question now and you come up with anything later on, then you can always leave it on the WhatsApp group.
Yeah, hi. There
Yeah,
is one M1, there is one M1, two M2, and two M3, right?
yeah.
Okay, okay. Just want to know. One
M1,
M1,
M2, M3, M4.
M3,
You're
M4 or one or
asking
two?
about the middle cerebral artery segments, right?
Yeah, yeah. M1 ends and bifurcates into two M2.
Yeah.
Then M3 and M4.
Yes.
Okay,
M1
M3, M4.
can sometimes bifurcate and M1 can sometimes trifurcate as well. There's
Okay,
anatomical variation in that.
okay, okay. And what about M3 and M4?
M3 and M4 are segments. They are not branches. I think you were asking if we have two segments, if we have two M2, then we will have multiple M3 and M4. They are not branches. We are talking about the segments. Let me draw here. Even though we are going to have a dedicated section on MCA. So this is M1, right? And then it
Okay.
bifurcates, right? This
Okay.
is and this is the
M2.
superior trunk. Yes, this is the superior trunk. This is the inferior trunk.
Okay.
They are both M2, right?
Yeah.
And then
Yeah.
they end up dividing in a lot of smaller branches, which were the
Oh,
insular branches, etc. All these branches are going to be M3. And then we have the terminal branches which go on the cortical surfaces. They are the M4. So the segments are not concerned with the branches. When we're discussing segments, we are only discussing segments. We don't care how many trunks there are or how many branches there are. Are you clear now?
yeah.
The segments are anatomical. They depend
Okay.
where in the lobe or where in the Sylvian fissure that particular portion is. What
Okay.
you might confuse it with are the branches, individual branches.
Okay. Okay. Thank you. Thank you.
Thank you. Thank you so much, everyone. I will upload the Sylvian fissure PPT on the drive as well and upload the link for this. Thank you so much. This is a wrap for today.